Je propose de démarrer cette conférence de presse à l'heure pour...
I suggest that we start on time. For those of you who are present, I would like to thank you first for your participation. It's a very special pleasure, pride, and honor of being today with my colleagues here to speak to you of a world first which took place at the HUGs a few months ago, and someone who is with us today, but who is not on the podium, but certainly the most important person of today, who is the beneficiary or recipient, and who will be speaking in a moment, but did not wish to be up on the podium, but who will be speaking in the press conference very directly. And I'd like to express my thanks, because at the HUGs we often say the really important issue is you, and a miracle which took place thanks to the professional teams who are with me and all the teams who are here. I would like to welcome all those who are working on a day-to-day basis to make these miracles possible. The HUGs is to care, of course, but also research, and we have the honor and pleasure of introducing in a world first an operation which took place here in our walls. And without any more ado, I'll turn to the main players, and I'm turning to Thierry Bernet. Thank you, Mr. Director General. Ladies and gentlemen, thank you for your presence at this press conference in which the HUGs and the transplant unit and infectious disease unit wish to discuss with you what seems to have been a major event in the field of health in general. My name is Thierry Bernet. I'm a surgeon and chief physician of the transplantation unit in the HUGs. I will start by telling you a story. In October 2015, one night I was woken up by Marie-Claude Kemp, coordinator of transplant, who was on standby, to tell me that Professor Emiliano Giostra, a specialist in transplant hepatology, had accepted the liver of a donor who died of cerebral hemorrhage. The donor and the recipient were both HIV positive. The law allowed, as the case for hepatitis C, a transplant between a donor and a recipient who were both infected. And with the reservation of the written consent of the recipient, I asked to be confirmed that all of this had been checked and was in line with law. I was told that my colleagues here present, Professor Van Delden and Gestra, had spent some time burning the midnight oil to be quite sure that everything would take place as best as possible and in line with law. The next morning, I undertook this transplant, not alone, of course, but the whole team, and my young and talented colleague, Dr. Alexander Rundas. And we were more concerned with having a good quality operation rather than wondering whether we had a Geneva first, a Swiss first, or a global first. The operation took place quite quickly without any incident, and after the brief intensive care passage, the patient accepted to be with us and was very rapidly back on his feet to be able to continue his outpatient treatment. Now, why is the possibility of a transplant of HIV-positive donor to a recipient also HIV-positive is so significant, and what are the medical challenges? A liver graft is a highly technical act, but a transplant, in this case, is a key link in a long chain of solidarity, which is a transplant operation, a chain of solidarity which goes beyond a donor and recipient and the medical and family environment. 31st of December 2015, 1,384 patients were on a waiting list for an organ, a growth over the year, despite the increased number of potential donors thanks to the remarkable work of Swiss Transplant. 65 patients, 24 waiting for a liver, passed away in 2015, awaiting the organ that was going to save their lives and which never became available. Mortality in the waiting list of HIV-positive patients is higher than that of non-infected patients, the transplant possibility of Mr. F with a HIV-positive donor, which could not be allocated to another recipient, made it possible to give him the liver he was awaiting, but also enable the person who was following him on the waiting list move up one rank and to become that much closer to the saving transplant. The situation of HIV-positive potential recipients are often co-infected with hepatitis C, which makes their care that much more difficult before and after the graft. The reject of the organ is also higher and requiring increased follow-up. In an approach which is as multidisciplinary as a transplant operation, we discussed amongst all the specialties the medical issues in order to carry out Mr. F and his transplant to full success. We then discussed the way in which could be the best time to communicate on this event, which was very significant. For reasons that were alluded to earlier, we decided to wait to have a 6-month period before any public notification. Mr. F, who is with us today, is doing very well. This was published today in the American Journal of Transplantation, and I don't regret in any way, despite the opportunity which is open to others of having observed this safety period. The transplant itself is a delicate technical act, but the true challenge is in the prevention of the rejection and the control of the HIV infection, which my colleagues will speak of. I would like to add that the success of the transplant opens the door to the implementation of such grafts from living donors for kidneys and for livers, as this would be allowed by law. I would also like to add that for me, the main progress and through this intervention or operation was to take into account the situation of HIV-positive patients as citizens equal to all others and being able to benefit from this donation. Thank you very much, and I'll turn to my colleague, Professor Alexandra Calmy.
Merci Thierry, merci Monsieur Levrat.
Thank you, Mr. Thierry, Mr. Levrat. Ladies and gentlemen, thank you for your presence. We are very happy to be able to communicate on this situation, which is quite special. My name is Alexandra Calmy. I'm responsible for the HIV/AIDS unit here at the Cantonal Hospital, and I was involved in the management of this situation when one morning in October 2015, and not in the middle of the night like my colleagues, I was asked whether I could give an opinion on the treatment of this patient who just received a liver transplant, the donor having the specificity of also being HIV positive. This situation seemed quite exceptional, and we were not able to refer to the experience of any other centers simply because this just did not exist, and yet I can assure you that we did a complete search. A liver transplant is not simply a technical intervention. The challenges presented by this type of surgery are medical, of course, but the societal challenges are quite significant. And I'd like to start with a few medical challenges that were quite important in this clinical situation. First, you need to know that the first global experience of an organ transplant from an HIV-positive donor to a recipient in the same situation was done in South Africa in a clinical research published in February 2015 and relating solely to kidney transplants. In such a situation, donors and recipients were very well sorted or selected in order to avoid they have a resistant HIV virus. Nevertheless, in Geneva, in this first liver transplant from a HIV-positive donor, the donor, just like the recipient, were both seropositive in this for a number of years, had undergone extensive antiretroviral treatments, as well as the most complex and the most toxic treatments that existed at the end of the 90s. The challenge here was dual. We needed to be able to monitor the multiplication of two strains, that of the donor and of the recipient. These two strains are different, being subjected to different treatments involving, thus, good knowledge of the donor's virus and being able to adapt the antiretroviral treatment at the recipient side. Here, the key role of the treating physicians, which will not be named for reasons of confidentiality, which documented the whole medical past over 30 years of resistances that have evolved over time. This work has been facilitated in Switzerland through the existence of the cohort study, which has a detailed listing of treatment and resistance over time. The importance of the monitoring of two different strains of the virus shows it was essential to wait until being able to communicate the success of the procedure. In the case which is before us, the dosage of the HIV dosage of the recipient was undetectable 6 months after the graft. The antiretroviral treatment had to be completed in relation to the initial treatment to the donor, but remains fairly simple to administer. It's also important to highlight the perfect compliance with the procedure to ensure success of the whole process. We already knew that liver transplants from a donor that would not be HIV positive to an HIV positive recipient could lead to quasi-identical success to that of other situations. Initially, I spoke of the medical challenges, but also the social challenges that such a graft could represent and does represent. Now, the progress in the care, HIV care makes it possible to see that the undetectability of the virus, in other words, a virus which cannot be detected with molecular techniques that exist in diagnostic procedures for most HIV strains that exist, and insofar as the patient can accept the prescribed treatment. HIV-positive patients have a life expectancy close to that of those who are not HIV infected. They live longer, they age, and their organ requirements are no longer exclusively related to the HIV illness or condition. We hope that this graft will have a major impact on the community of those living with HIV and on their medical personnel. Firstly, because those living with HIV can give their organs, have with them a donor card with a message saying, yes, the organs of someone living with HIV can also save lives. Secondly, by potentially reducing the waiting time for a liver transplant, often the only therapeutic possibility for acute liver diseases, at a time when hepatitis C, which is a frequent cause of liver transplants in this population, is not yet universal. Thus, we hope that this will make it possible to put an end to the discrimination which is felt by the majority of people living with HIV throughout their lives. Thank you for your attention, and I turn to Professor Christian van der Breden.
Thank you, Alexandra. Thank you, Mr. Director, ladies and gentlemen. My name is Christian van Delden. I'm a specialist in infectious diseases and I'm responsible for the unit at the Geneva University Hospitals of infectious diseases. In fact, all of this began back in 2006. We were consulted by the Federal Office of Public Health in the context of an expertise to determine the selection of potential organ donors, limiting the risk of transmission of infectious pathogenic agents from the donor to the recipient. Experts and other staff at the IFSP who were responsible for drawing up the decree or the ordinance were actually against this approach to draw up the list of donors who were HIV positive. They obviously wanted to put the emphasis on the safety of transplant. But in fact, several rules had been implemented in a number of countries. In other words, the exclusion of HIV-positive donors for organ transplant. Our frustration was all the greater since we were already, as of 2006, losing a number of patients on the waiting list, and amongst those there were seropositive or HIV-positive patients who could have benefited from such organ transplants. Finally, it was Mr. Pascal Couchepin. I would like to thank him. He was a federal councillor at the time responsible for health who accepted to receive us personally, and we wanted to explain our position. We were able to convince him that the risks incurred were lower than the potential benefits. And it's thanks to his personal intervention that the Ordinance 810-11 relating to the transplantation of organs in 2007 authorizes the transplant of organs from HIV-positive donors to HIV-positive recipients, which is a world first. Other countries have moved in that direction since then, South Africa in particular, as Dr. Alexandra Calmy mentioned, with the transplant of kidneys from HIV-positive donors to HIV-positive recipients in certain very special circumstances, always with the idea of minimizing the risk of transmitting a pathogenic agent. The U.S. as well. In 2015, President Obama signed what was called in the States HOPE Act, a very important act that authorizes the implementation of a transplant program from HIV-positive donors, but only within a very restricted context. And it's in spring 2016 that a Baltimore transplant center received the necessary authorizations to carry out this type of surgical procedure. And like for Thierry in 2015, when I received a call in the middle of the night, and of course this referred to the decree that I was talking about, the possibility of making such a transplant. The information had been conveyed to the person in charge of the unit, the deceased of the donor, who actually had a card, but the patient had been informed by the attending physician of the right to sign a donor card. This was just a few weeks before the donor passed away. The procedure at HUG meant that I was called whenever there's a risk relating to the transmission of an infectious agent following the transplant of an organ. I talked to my colleagues, and we realized that the ordinance actually gave us the possibility to use the organs of the donor if the recipient was also HIV positive, and that all of the measures had to be taken, of course, to reduce the risk of transmission for the recipient. I obtained all of the information that I required relating to the decease of the donor and the control of his HIV. I was able to make sure that the potential donor had died from cause that was independent of AIDS, that the HIV virus was well controlled, and there had been no complication linked to his condition. I felt at the time that the risk relating to the transplantation of his organ, of his liver, was lower than the risk of decease of the recipient, and I gave the go-ahead to be able to identify a recipient, a HIV-positive recipient, and also to make sure that the recipient would be fully informed of the risks at hand. And I then spoke to the recipient and talked about the advantages and risks of the graft, of the transplant, and the recipient signed the authorization, gave his go-ahead freely, his consent, and this transplant has made it possible to give a second opportunity in life to this patient. As my colleagues have explained, this is a new source of hope for many patients, for HIV-positive patients who are on the waiting list. Any increase in the pool of potential donors means that they have a better chance to receive an organ transplant rather than to die while they're waiting for the transplant. And then the HIV-negative patients who are also waiting for organ transplant, the fact that there'll be less people on the waiting list means they have a better chance of receiving a transplant. And for all of those who are living with HIV today, and the discrimination that they are subject to, the fact that they can be a donor today is something that is wonderful for them. On behalf of the donor, the recipient of this transplant, and the respective attending physicians and all of the medical teams which participated in this transplant and made this transplant possible, I would like to encourage the legislators of other countries to follow the example of Switzerland, to lift this discrimination, which means that justice would be rendered to HIV-positive patients and increase the chances of HIV-positive recipients. Thank you for your attention. I'm now going to give the floor to the patient who's here anonymously. Hello to all. I would like to thank the entire medical team of the Geneva University Hospitals for everything that they did for me. everything that was explained to me. I had many doubts at the time relating to the risks of this organ transplant. To receive a liver from somebody who was HIV positive, as I was, in fact, well, I can say that myself and my family, we had a number of questions in our minds. We had a certain number of doubts with my next of kin, and the entire team reassured us and said that the transplant would work and that we should really take advantage of this liver transplant. I would like to thank all the physicians here at the Geneva University hospitals and that have given me an opportunity, a second opportunity in life to be a fully fledged person. And I've never really experienced severe difficulties being HIV positive, but I can tell you that my liver was in a dire straits. I was very happy and relieved to be able to benefit of a transplant of the liver from this donor, this very generous donor, whom I'd like to thank. And often I'm at a loss for words, because I am so grateful to all of these attending physicians, associate professors, nurses, and others, and the donor himself. All of them are my family members today, and it is a tremendous honor and a privilege to have been able to meet these wonderful people. My life has been completely changed, turned upside down in a positive way. I had lost interest in life. I stopped eating. I thought I would never succeed in my battle to save my liver. Today I have a new liver. I'm somebody who's very happy. I've put on a lot of weight, 10 kilos over the last 6 months, in fact. I'm very, very happy, in fact, and also very happy to see the smiles back on the faces of my family members. All of this is a source of hope. I see life differently. I have different prospects today and more hope, and also the donor and his family. And in this respect, I would like to thank them, and I would like to thank the family of donors who sometimes have to decide in the place of the donor who has passed away. Their decision is very important. If you can give life to somebody, extend somebody's life, as was my case, this is a wonderful gift. It is a once-in-a-lifetime opportunity. Thank you very much. Thank you, Mr. F., for your account, for your testimony. I think we can now come to the Q&A part of this session, of this press conference. I would like to know whether there are any questions from the people present in this room. Ladies and gentlemen, either to us or to the patient. There is a roving microphone. David Ramseyer, 20 minutes, 2 questions, if I may. First, when there are transplant cases for a HIV-positive person, the donor is not HIV positive, you said that there was a greater chance of rejection of the transplant. I'm not a doctor, so I don't understand all of this in detail. But what are the differences that can exist for a recipient, whether the donor is HIV positive or HIV negative? The second question is, as regards a transplant from an HIV positive to HIV negative recipient, what would be the impact, taking into consideration the many people who are on the waiting list for an organ transplant? Well, I'll answer your first question. As regards the transplant of HIV-positive recipients from HIV-negative donors, this is done throughout the world very extensively, and in Switzerland, in Geneva in particular, at HUG, for the last 10 years at least. The risk of rejection is slightly increased. We see this in major studies. It is a fact. One of the explanations of this might be that the immunosuppressant medication interferes with the dosage of the antiretroviral treatment, triple therapy in particular, and reciprocally as well, this can have an impact on the rejection rate. Rejection is a major issue for us. We follow this very closely in all of our transplant patients, all those who've received a graft, in particular a liver, and HIV-positive patients in particular. And in the case of liver, the rejection is something that is relatively more easy to control than other organs. And then the second question, Alexandra, would you like to answer? Well, we could answer this together with Christian. We're talking about discrimination, so your question is a very good thing. We would like to put an end to this discrimination. Maybe we're not ready today to make sure that seropositive HIV-positive organ be transplanted into HIV-negative recipient. So there's still chronic treatment. This is something that has to be taken into account as opposed to hepatitis C, for instance. The second point is that these transplantations that we're talking about today, there have been only 2 in the world today, at least to my knowledge, so we're waiting to have a little more feedback on these transplants to be able to come up with maybe more precise responses. Christian, yes, this is a question that we can raise, indeed. We should not move ahead too hastily and follow each step. I'm very happy that we've been able to do this world first here between 2 HIV-positive patients, the donor and the recipient. In the future, this might be a possibility, but we need to make sure that there's 100% safety and security of the surgical procedure that is carried out. 6 months is not enough in terms of follow-up. We need to have carried out the surgical procedure in a large number of patients to make sure that security and safety do exist with a large array of patients, a large cohort, and this in different countries. But subsequently, it is quite possible that once we have been able to reassure everybody, and the physicians in particular, and the patients receiving this type of organ, we'll be able to turn to the legislators to see whether it's possible to change the laws. But this will take some time, several years, no doubt. With the microphone, please. Is this operation possible if the donor is still alive? And what are the risks with respect to an HIV-negative recipient?
You're speaking of the possibility of a transplant from a living donor. The law authorizes it, and it's something which could be foreseen. But you need to know that when you're in a situation of organ transplant for a living donor, it's almost easier than what we experienced, because you can prepare the transplant from the donor and the characterization of the virus. But here I turn to my virologists and infectiologist colleagues to give you a bit more detail. But the answer is yes, in theory it's possible and legally allowed. I would say that it's a situation which is even rather favorable in a situation of a living donor, because you can anticipate, prepare, be quite sure of the roadmap of the donor's virus, which we don't always have time to do when we get a call in the middle of the night. So it's rather a preferred situation in respect to a HIV positive transplant.
Bonjour, est-ce que vous pouvez détailler un peu?
Could you try to explain what were the challenges that you encountered to combine the immunosuppressors with the antivirals? The challenges may be a very large word. In any organ transplant, the immunosuppressors are administered in relation to target blood samples, which are predetermined depending on the risk of a rejection of the organ. All our patients are monitored quite closely for residual blood rates of immunosuppressors. As of that point in time, we are far more attentive, more particularly in relation to changes of antiviral medications, which can intervene because of the differences between strains. We know that some of these administrations can increase the rates, and inversely, a change can drop it. So we need to be very careful here. Our work is to monitor these rates very closely in collaboration with our colleagues and knowing at what time antiviral medication may be adapted or changed or shifting from one to another. Yes, we also choose the antivirals that have the least possible interaction with immunosuppressors. With the improvement of the range of antiretrovirals, we have more and more options to offer the patients to avoid any interaction. That being said, it is not very different from transplants from a donor that would not be HIV positive. We know which interactions can come into play between antiretrovirals and immunosuppressors. These can be anticipated and monitor them through plasma rates, as Professor Bernet just explained. This is a challenge, granted, but one to which we are better prepared.
Bonjour, Virginie Maternelle.
Virginie Maternelle, RTS, Swiss Television, radio television. There have already been clinical trials of transplant organs with HIV patients for kidneys some years ago in the US, if I'm not mistaken. So, this is in the framework of clinical research, February 2015, published in a medical journal, a trial on a group of patients under 10 in South Africa that had received kidney grafts in HIV-positive patients in South Africa on very well-selected patients to avoid any resistant strains of HIV. In the clinical situation that we had here in October, this would not have been eligible for the clinical research that was undertaken in South Africa. There have been no HIV positive to HIV positive in the U.S. up to 3 or 4 weeks ago, a transplant that was covered by the media, but covered a few days after the operation, without now this time lapse you have to be able to really see what is happening. And to our knowledge, there are 2 situations of this type that have been communicated, that of Johns Hopkins 3 or 4 weeks ago, communicated on 30th of March, and the situation that is being presented today. Practically, how many HIV-positive patients are awaiting a transplant in Switzerland? The million-dollar question, $64,000 question, I should say. 5 or 6 for liver transplants. Kidneys, a few more. It's hard to give you an exact countdown of a number of potential transplants that could be undertaken through this approach. We calculated through extrapolation 1 or 2 additional donors in Switzerland per annum. When you speak of organ transplants, Switzerland's a small country. What you need to see in such a situation is the beneficial potential our country can have by being pioneers in this type of surgery and opening the door to this approach in other Western European countries and encourage or facilitate the activities undertaken in the U.S. In countries like the U.S., it has been calculated that this represented some 500 additional transplants per annum. But in a country that's far larger than Switzerland, and where the infection rate is slightly higher than that of Switzerland.
Merci, bonjour, Deborah.
Deborah Glisser, CIDA, Genève. If Switzerland is authorized this 2007, why did you have to wait 9 years to have this first? Christian, Van Delden may have already prepared the answer. I was expecting the question. This relates to elements of chance and others that relate to a lack of information on the part of physicians and patients living with HIV. The first step to be undertaken is that the HIV positive person needs to know they can sign a donor card. A number of people living with HIV don't even know this. And this has been possible since 2007. A number of physicians didn't know about this. And here I can but welcome this family physician who, A, was informed himself, then informed the patient and informed other patients who are HIV positive of their right to sign a donor card. And I can but congratulate him for this. At the same time, you need to understand you need to have a match. This is an emergent situation at night. And here I can once again say that the donation of a living organ would be that much easier. In the middle of the night, we had to evaluate whether the risks of such a transplant are less than the advantages. I mean, what are the risks and advantages? The risks, first, transmission of a potentially resistant virus. Here, the archived cohort helps us to find the data. Was the patient well followed? I'm speaking of the donor. The donor, there any opportunistic infections or illnesses which could have an impact at the time of the transplant, because when the person dies, there's no more control. The person may have died of an illness related to AIDS that could be transmitted to the recipient. So this is where you have to have a very rapid evaluation, which is not always easy. Here we were very fortunate. At the same time, you need to understand that there's a potential risk, is that the organs may have suffered a very long exposition to antiretrovirals, some of which are toxic for the organs you want to transplant. So it's all this group of data of the correct match and all the required data, which meant that we had to wait for some time. We hope that the next intervention will be in a shorter time period. I'd like to add something. There's also a question of confidence of the medical staff and the patient in relation to the donation of organs. When you speak to potential patients, which I've been doing since the situation with Mr. F., the first response is, no, not me. I mean, I'm HIV positive. I cannot be an organ donor. So it's information, but also confidence that the patient may have, and the confidence of the medical personnel. You have to put your mind back to 2007. The tritherapies were not the same as today. It was far more complex. And I'm not convinced that all the viral strains could have been covered satisfactorily in 2007 and may have required a more refined selection than what we could do here. So the issue of confidence and information are both very important. If I may, I'd like to come back to the 2007 date, which shows that Switzerland is a pioneer country. But why is Switzerland a pioneer country? Well, it's rather ironic. Up until 2007, there was no federal law on organ transplants, only cantonal laws, and not all cantons had such a law. The fact that we had to wait this long before finally having a national law, or federal law, made it possible to draft it and implement it, as Professor Van Delden just explained, at a time when the tritherapy progress was such that this became not only something possible, but potentially beneficial. And that explains why other countries have had transplant laws way before us. In fact, are the ones who seem to be lagging behind in relation to Switzerland. Well, ladies and gentlemen, if there are no more questions, I would like to thank you. Of course, we are at your disposal. I'd like to thank the patient, Mr. F., who is here, and to remind you that if Switzerland is a progressive country, carrying a message of hope. Switzerland, in the field of organ transplant and organ donors, country of the rest of Europe, presupposes that you have to give your consent upstream, and therefore I can encourage you by using donor cards and this ECHO 112, an excellent application, so that people can actually ask themselves the question whether they should be organ donors. Two figures. 2 people die every week because there are no organs, and yet we have the teams, we have the know-how, and we could save them if the organ were available. The second figure is 17 people have died in the HUG, whereas we had the teams, the professionals, and the ability to save them, had they not been simply on a standby waiting list. The message is therefore a message of hope. HIV-positive patients can be organ donors, and those who are victims of HIV can also receive organs. But I would like to remind you where legislation in organ donors presupposes that upstream consent is given. Otherwise, we'd ask the family or the relations whether they presuppose there is consent. It's important to give such a message in concluding this press conference. There's the ability to carry out miracles in this hospital, which is one of the best European hospitals, which needs to be recalled. And at the same time, we are confronted with a shortage of organ donors. What we have succeeded to do with excellent teams, I would like to thank, makes it possible to all those on the waiting list to move forward in finding an organ. And of course, we remain at your disposal. Once again, my thanks to Mr. F. for having been with us today, and I wish you a very pleasant day. Thank you, our Director General, Mr. Bertrand Levrat, of having been with us and thus expressing his support.